Welcome to the deep dive. We're kind of your shortcut to getting really well informed. There's just so much information out there, right? Our mission is simple. Take your sources, your notes, whatever you've got, and pull out the absolute key insights, help you cut through all that noise. So today, we're diving into something, well, really fascinating and important in the horse world. It's an enzyme called creatine kinase, CK for short, and we're looking at its role, its really profound role in understanding muscle disorders in horses. It's almost like uncovering the silent language of their muscles. And whether you own horses, ride them, or maybe you're just curious about animal physiology. Common, often confusing issues, muscle problems, that dreaded tying up. So what is CK? What do those lab numbers actually mean? And how can understanding this stuff really help your horse? Okay, so let's unpack this. What exactly is creatine kinase, CK?
Right, so CK, it's what we call a cytoplasmic enzyme. Basically means it lives inside the main fluid part of the cell, the cytoplasm. Think of it like a tiny worker in the muscle cell's energy factory. Its main job, its core function, is super vital. It handles the conversion back and forth between creatine phosphate and ADP, that's adenosine biphosphate, to make creatine and ATP adenosine triphosphate. And that ATP, that's the immediate fuel for muscle contraction. In fact, CK's work provides the only source of energy right at the very start of exercise. It kicks things off. Now, where is it? Mostly in skeletal muscle, also heart muscle, and a little bit in the brain. But, and this is really key for horses, while big jumps in blood CK can technically come from heart damage, we almost never use it for that clinically. For horses, high CK usually points us straight towards skeletal muscle injury.
Okay, that makes sense. Focus on the skeletal muscle. So if it's this alarm bell for muscle damage, what happens when those cells get injured? How fast does CK show up in the blood?
Well, when muscle cells are damaged, CK just leaks out. It floods into the bloodstream pretty rapidly, which makes it a highly sensitive marker. And its kinetics, how it behaves over time, are fast. The half-life in serum for horses is less than 2 hours.
Less than 2 hours, so half of it is gone that quickly.
Exactly. Half-life means half of what's in the blood gets cleared out in under 2 hours. So it spikes fast, but it can also disappear relatively quickly if the damage stops. After an injury, you typically see the peak activity in the blood within, say, 4 to 12 hours. Different sources give slightly different ranges, but it's in that ballpark. And then it usually heads back towards normal within 2 or 3 days, maybe up to 7 days sometimes, if the damage isn't, constantly happening.
That is incredibly fast. So does that mean timing is crucial? Like if an owner waits a day or two after seeing stiffness, could the CK levels already be dropping, maybe masking the severity?
That's a really excellent point. And that's a practical challenge, that rapid clearance. It absolutely means timing matters for those blood draws. If you suspect something's wrong, getting blood drawn relatively soon after you notice signs gives you the best shot at catching that peak CK level, seeing the true extent of active damage. Wait too long, and yeah, you might miss it or underestimate it. And the size of that increase, the severity, it directly reflects how bad the active muscle injury is. So for example, you might see modest increases, maybe under 1,000 IUL, that's just the unit we measure it in, international units per liter. These can happen in normal horses just from training or transport, even regular exercise. Often you won't even see a rise in the other muscle enzyme, AST, with these. Endurance rides, though, they might push CK over 1,000 IUL. But even then, it usually comes back down within 24 to 48 hours. Even something simple like an intramuscular injection, a shot, can cause a mild to moderate bump. That's why your vet might ask, any recent injections?
Okay. Good to know.
But then you get the really dramatic spikes. Thousands, maybe tens of thousands, sometimes even over 100,000 IUL.
Wow, 100,000. That's huge.
It is. And those huge numbers, they signal much more serious things are likely going on. Conditions like PSSM, polysaccharide storage myopathy, or severe exertional rhabdomyolysis, immune-mediated muscle diseases, or nutritional myodegeneration, which folks sometimes call white muscle disease. Although even in some milder chronic forms of exertional rhabdomyolysis, CK might hover somewhere between, say, 1,500 and 10,000. And it's also worth remembering, with HYPP, that's hyperkalemic periodic paralysis, the CK levels are often normal or only slightly up, even when the horse is having an episode.
Right. So what's really striking here is that CK tells us if there's damage and roughly how much. But like you said, it doesn't pinpoint the cause. It's the alarm, not the fire report. So how much then does the vet rely on what the owner sees, the history, the specific signs, to start piecing together the puzzle before even getting those blood results back? And what does this mean for those common muscle issues we see?
You nailed it. That high CK, It's not the end of the story. It's really the beginning of the detective work. It forces us to dig deeper, consider all these possibilities. And yes, the owner's history, their observations, what happened before. What exactly did you see that's absolutely critical? It provides the context to interpret those numbers. Now, when we talk about common muscle problems, people often use the term tying up. Technically, that refers to rhabdomyolysis. It's basically a syndrome, right? Muscle fatigue, pain, cramping, actual breakdown of the muscle tissue. And it can happen sporadically, like a one-off event, or it can be chronic, a recurring problem.
Okay, so how do we tell the difference between those common forms? Because, yeah, tying up gets used for almost everything sometimes.
Exactly, it's an umbrella term. So the most common type is sporadic exertional rhabdomyolysis, sporadic ER. This is usually what happens when a horse has worked harder than it's fit for, or maybe it had a few days off with full grain feed and then went back to work, or sometimes exercising in really hot, humid weather, or if electrolytes are out of whack. The signs are pretty classic. Sudden stiffness, seems painful, doesn't want to move. The muscles, especially where the hindquarters and back, feel really firm, even hard, and painful to touch. Often they're sweating, breathing hard, heart rate's up. And in really severe cases, the urine might look dark, like reddish-brown. That's from myoglobin leaking out of the damaged muscle, myoglobinuria. That can be tough on the kidneys if it's bad.
Okay, so that's the one-off, the sporadic kind. What about the horses that keep doing it, the chronic cases?
Right, so then you've got chronic exertional rhabdomyolysis. This means recurrent episodes. And under this umbrella, there are actually several distinct conditions. There's recurrent exertional rhabdomyolysis, or RER. We see this mainly in breeds like thoroughbreds, standardbreds, some Arabians. The thinking is it's a genetic thing. It involves abnormal calcium regulation inside the muscle cells, makes them kind of hyperexcitable. It's often triggered by excitement, stress, high-starch diets, or even just inconsistent exercise schedules.
So like a racehorse that gets anxious, maybe gets a lot of grain, hasn't worked for a day or two, that could be RER.
That's a classic scenario, yeah.
Mm-hmm.
Then you have polysaccharide storage myopathy, PSSM. This one's metabolic. The muscle cells store glycogen sugar basically abnormally, either too much or in an abnormal form. There's PSSM type 1, PSSM1. We know the cause here. It's a specific genetic mutation, the GYS1 gene. You see it a lot in quarter horses, paints, Appaloosas, many draft breeds, even some warm bloods. And interestingly, some PSSM1 horses can have constantly elevated CK levels even when they're not showing obvious signs of tying up, sort of simmering muscle damage.
Oh, really? So it can be subclinical?
It can be. Then there's PSSM type 2, also abnormal glycogen storage, but they don't have that GYS1 mutation. The diagnosis for PSSM2 usually requires a muscle biopsy. We see this in various lighter breeds too, quarter horses, Arabs, warm bloods. And more recently, we're recognizing myofibrillar myopathy, MFM. This seems particularly relevant for Arabian endurance horses, maybe some warm bloods too. With MFM, the problem seems to be within the myofibrils themselves, those tiny contractile units inside the muscle. Signs can be muscle pain, stiffness, maybe muscle wasting or atrophy, often showing up towards the end of a long ride or even after short rest periods. So for all these chronic forms, the common theme is recurring episodes of tying up, often triggered by light exercise or even just rest days if they're on high carb feed, plus stiffness, soreness, not wanting to move, maybe muscle tremors, fasciculations, and sometimes muscle loss over time. Draft horses with PSSM, for instance, can really show progressive weakness.
Okay, wow. So tying up really is just the symptom. It's not one disease at all. That's a huge takeaway. Thinking broader then, what else can cause high CK that isn't necessarily related to exercise or these specific chronic conditions?
Oh, absolutely. Beyond the exertional types, there are other important causes.
Yeah.
Direct trauma is a big one. Falls, getting kicked, even just being down for a long time, recumbency maybe after a tough foaling or surgery, even struggling hard during restraint or having seizures, that intense muscle activity can cause CK to spike. Then there are toxic myopathies. Less common, thankfully, but they can be really severe, even fatal. We have to think about accidental exposure to things like ionophores. Monensin is an example. It's sometimes in cattle feed, but toxic to horses. Certain plants, too. Box elder seeds are a known problem. Those trees are pretty common in the central and eastern U.S. And white snake root, another native plant in those areas, contains a toxin called trematol. Both can cause serious muscle damage.
Plant toxicity is okay. What else?
Nutritional deficiencies. A really severe lack of vitamin E and selenium can make muscles vulnerable to damage. This is particularly known in foals, often called white muscle disease, or NMD. You also have rare genetic conditions like malignant hyperthermia, MH, seen in some quarter horse lines. It causes this crazy, uncontrolled surge in muscle metabolism, severe rigidity, super high fever, and yes, sky-high CK. Viral infections too. Things like equine flu or EHV1 can sometimes cause muscle inflammation, viral myositis leading to elevated CK. Sometimes horses seem to have a sort of post-viral fatigue with lingering muscle soreness. And we should also mention severe heat stroke and certain nasty bacterial infections like Clostridial myositis, gas gangrene in muscles, essentially. Just thinking about risk factors generally, things like improper conditioning, like asking for too much too soon after time off, being down for any reason, exposure to those toxins we mentioned, even just the stress of trailering or restricting feed and water before a trip can sometimes be enough to tip a susceptible horse over the edge. It's a wide net for sure.
Wow, okay. Yeah, that is a wide net. It really drives home how challenging this must be for vets. So that begs a question. With all these possibilities, how do they actually figure out what's going on? How do they get to the bottom of it and land on a specific diagnosis?
It's definitely a process, a bit like detective work, as you said. It usually starts with the laboratory findings, primarily blood and sometimes urine. A baseline CK level, taken when the horse is at rest, gives you a starting point. Then, if you suspect an exertional myopathy, that post-exercise CK sample is really key, typically drawn about 4 to 6 hours after a standardized controlled exercise test, maybe 15 minutes of trotting, something consistent. If that post-exercise CK is significantly higher than the baseline, say it doubles or more, or if the absolute number is just really high, that's strong evidence for exercise-induced muscle damage.
Okay, so baseline, then exercise, then test again a few hours later. Makes sense.
Exactly. And often we'll do serial CK monitoring. That means taking measurements repeatedly over days to see if it's going up, coming down, how quickly. It helps track severity, see if the damage is ongoing, and monitor if the treatment is working. We also look at AST, aspartate aminotransferase. That's another enzyme found in muscle, but also liver. Its levels rise more slowly than CK, maybe 12 to 24 hours after the injury starts. And critically, AST stays elevated much longer days, even weeks. So CK is your immediate flare, your alarm bell ringing right now. AST is more like the lingering smoke or damage report. It tells you something happened recently and might still be resolving.
So using them together gives a better timeline.
Precisely. If CK is still high, the muscle damage is likely active, ongoing. If AST is high, but CK is coming down nicely, the active damage phase is probably over and the muscle is starting to heal. It helps differentiate acute versus chronic or resolving issues. We might do a urinalysis, especially if the urine looks dark, to check for that myoglobin. Remember, myoglobin is tough on the kidneys, so confirming it is important for management. But just because the urine looks normal doesn't completely rule out milder chronic tying up. Other blood tests might look for signs of inflammation or infection, check vitamin E and selenium levels. And if toxins are suspected, there are specific tests, like looking for acylcarnitines for box elder or trematol metabolites for white snakeroot. And a practical note, sample handling matters. If the blood sample isn't handled right, or if it's hemolyzed, meaning red blood cells burst, it can mess up the results. Even really high CK activity can sometimes interfere with the lab machines, requiring special steps like dilution.
Good point. Okay, so blood tests, urine tests. What else is in the toolkit?
Beyond the labs, genetic testing is really useful for certain conditions. We can test for the specific GYS1 mutation for PSSM1 and the RYR1 mutation for malignant hyperthermia. Usually just need a hair root sample or a blood sample. Muscle biopsy is often called the gold standard, especially for diagnosing PSSM2, where there's no gene test yet, MFM, or maybe subtle cases of other chronic myopathies. A small piece of muscle tissue is taken and sent to a specialized lab for analysis.
Biopsy sounds invasive, but I guess sometimes it's necessary.
It is more invasive, yeah, but sometimes it's the only way to get a definitive answer for those conditions without a specific gene test. Electromyography or EMG might be used. It looks at the electrical activity in muscles, which can help rule out nerve problems or give clues in conditions like HYPP. And finally, the vet always performs a differential diagnosis. They consider all the other things that could potentially look similar, like colic, laminitis, even neurological issues like equine motor neuron disease, or other things that cause dark urine, like severe dehydration or certain toxicities like red maple leaf poisoning. They have to rule those out.
That's a really comprehensive process. Okay, so let's bring it back to the horse and owner. Once you have a diagnosis, or at least a strong working diagnosis, what does management look like? How do you help the horse recover from an episode and hopefully prevent future ones?
Right. The management really hinges on that diagnosis, but there are common threads. Let's talk about managing an acute tying up episode first. The absolute first step, stop exercise immediately. Don't walk them, don't force movement, keep them still. Even a short walk can make the muscle damage worse. Pain relief is crucial. Usually NSAIDs, like bute or banamine phenylbutazone or flunixin meglumine to reduce pain and inflammation. But here's a really important but. If you suspect myoglobinuria, if that urine is dark, you have to be cautious with NSAIDs. Myoglobin can damage kidneys, and NSAIDs can also be hard on kidneys, especially if the horse is dehydrated. It's called pigment nephropathy, and it can be serious, even leading to irreversible kidney failure without aggressive fluid support.
Okay, big caution there with the dark urine. Got it.
Definitely. Muscle relaxants like methocarbamol might be given. Sometimes dantrolene sodium is used. It helps by reducing calcium release inside the muscle cells, which can calm down that hyperexcitability in some conditions. Hydration is key. Make sure they have fresh water. If they're dehydrated, sweating a lot, or have that dark urine, intravenous fluids, 5E fluids with balanced electrolytes are often essential. This helps flush the kidneys and get rid of that myoglobin. Fluids might need to continue until they're hydrated and the urine looks clear again. Other supportive care includes things like blanketing if it's cold, giving them deep bedding in a stall initially, usually for the first 24-48 hours of rest. Then, once the pain starts to ease up and those CK levels begin to drop, it's about a very gradual reintroduction to exercise. Super slow. Maybe just hand walking for short periods, then small paddock turnout. No sudden changes in routine.
Okay, that covers the immediate crisis. What about preventing it from happening again, the long-term plan?
That's where things like dietary modification become absolutely central, especially for conditions like PSSM and often for RER too. The cornerstone is usually a low-starch, low-sugar diet. We talk about non-structural carbohydrates or NSC. Grains, corn, oats, barley, sweet feeds are typically high in NSC and need to be drastically reduced or ideally eliminated for these horses. Instead, you meet their energy needs with high-fat and high-fiber diets. Things like beet pulp without molasses, soy hulls, these are good digestible fiber sources. And fats like vegetable oil or stabilized rice bran provide energy without the sugar spike. Fat is considered a cool energy source. It can sometimes help reduce excitability too.
So less grain, more fat, and fiber. What about hay?
Good quality forage should always be the base of the diet. Grass hay is usually preferred. For PSSM horses, it's often recommended to get the hay tested for its NSC content to ensure it's suitably low. Pasture can be great, but again, might need management depending on the horse and the pasture quality. And of course, making sure they have balanced vitamins and minerals. Vitamin E and selenium are particularly important for muscle health, but you don't want to overdo it either. Just ensure adequacy. There are also special considerations, like if a horse can't swallow properly due to a toxin, they might need tube feeding or IV nutrition. And horses with both PSSM and HYPP need extremely strict dietary control.
Diet sounds huge. What else? Exercise.
Absolutely critical. A consistent exercise program is key. Regular daily exercise, even if it's just light work or turnout, helps manage these conditions much better than stall rest, followed by sudden work. In fact, regular exercise actually decreases the likelihood of exertional rhabdomyolysis episodes. Avoid those long periods of stall rest, because that's often what triggers an episode when they do go back to work. Always include a good warm-up and a gradual cool-down. And as much daily turnout as possible is usually beneficial. It encourages movement and reduces stress. For horses with RER, environmental management is also important. Minimizing stress and excitement in their routine, calm handling, consistency that can make a difference. Sometimes medications are used long-term for recurrent cases. Dantrolene might be given before exercise for some RER horses to help stabilize that calcium regulation. Ace-promazine, a mild tranquilizer, is sometimes used carefully in very excitable horses prone to RER to just take the edge off. And finally, electrolyte supplementation. Important for any horse working hard, especially in heat, but make sure it's balanced. And always provide free choice access to plain salt. So yeah, managing these disorders is definitely a team effort, owner, trainer, vet, sometimes nutritionists all working together. The outcome really depends heavily on what the specific underlying cause turns out to be.
We've really covered a tremendous amount of ground today, haven't we? I mean, from the nitty-gritty science of CK being that muscle alarm bell right through to the different kinds of tying up other causes, and this really comprehensive approach to diagnosis and long-term care.
We certainly have. And I think the real key takeaway for you listening is that understanding these details, these nuances, really empowers you. It helps you be a better advocate for your horse, whether it's a high-level athlete or a pasture companion. It's about moving past just seeing symptoms to really getting what might be going on underneath and knowing what questions to ask, what steps to take.
Absolutely. So here's something to think about. Knowing just how sensitive CK levels are to muscle activity, to diet, and thinking about all those risk factors we talked about, what's maybe one single change you could think about implementing today? In your horse's routine or their diet, something that might proactively support their muscle health even if they've never shown any outward signs of trouble. Just some food for thought. Until next time, keep diving deep.